Thank you very much for the kind invitation, dear colleagues. My topic is hypertensive disorders of pregnancy and CKD. And so I will proceed with the definition of what is, which are the hypertensive disorders, whether there can be an association with kidney disease and what these might be, risk factors and comorbidities, and then some epidemiological data. So starting with definitions, gestational hypertension refers to hypertension presenting after the 20th week of gestation, a new onset hypertension, more than 140/90, at least twice, and when it's combined with proteinuria, then it's called preeclampsia. But just because 10 to 30% don't have proteinuria, they should have another criterion which comes from either other maternal and organ dysfunction recognized on top of newly diagnosed hypertension or uteroplacental dysfunction. So what might be the association? Is it a villain or is it a bystander? There are common things. We'll do this by examining where there's a specificity for the injury associated with the pathophysiology of preeclampsia per se, or whether there's underlying disease, especially renal disease, that might flare and accelerate during pregnancy, or just some common risk factors that can be associated with renal injury. So let's start with the first. We know that in normal pregnancy, there's a stress test for the kidney. We know there's a rise of almost 40% for GFR. And we know that we have a drop in the normal blood pressure, as in contrast to non-pregnant women. In normal pregnancy, we have a diminished responsiveness to angiotensin. The drop is almost 17 millimeters of Ag, and we don't have this in preeclampsia. So there's ultrafiltration and decrease of blood pressure in normal pregnancy. But on the other hand, when we have preeclampsia, we have hypertension and proteinuria. And proteinuria means that there's a problem with either the endothelium or the epithelial cells, or the barrier in the glomerula might have a problem. And let's just check out which might be the problem. Is there an issue with endothelium? Yes, there is. We know that the classic lesion is glomerular endotheliosis. We've got these swollen endothelial cells, and we've got also the loss of endothelial fenestrations. And we know that anti-angiogenic factors that come from the ischemic placenta produce maternal endothelial dysfunction. They are all over the mother's body. And they do this as soluble forms, the SFLTs and the SENG, forms of the receptors that are released from the ischemic placenta act as antagonists and actually lock and prevent the adherence of VEGF, TGF onto the endothelial receptors. This paucity of interaction and drives an endothelial dysfunction and vasoconstriction in the mother. And we know that the levels of SFLTs rise proportionally to the severity of the preeclamptic disorder. And we also know that we have confirmatory experimental models where administering SFLTs can produce glomerular endotheliosis very similar to what happens to women. We even know that this endothelial dysfunction can last even after 1 year later. So the endothelium, we know, we have evidence that it's damaged during these syndromes. What happens about the podocytes? This is data from autopsy, so we have kidney specimens from deceased women, and we can see there are pregnant women with preeclampsia with the yellow. There are pregnant controls. Then we have hypertensive controls and normal controls. And we can see that endotheliosis can discriminate. It's a much higher percentage of the women with preeclampsia have a higher percentage of endotheliosis in the kidney specimens. However, the podocyte changes in tram trafficking are much more specific than endotheliosis. And what's more, in these specimens, they found there's a higher level of replacement of the lost original podocytes from migrating differentiative parietal epithelial cells. We know now that they have spares in the capsule of Bowman that actually go and fill the gaps from any damage that can happen to the epithelial cells. And they found that women with preeclampsia, diseased women with preeclampsia, had a higher percentage of these cells, thus showing us that there's a severe extent of podocyte injury also, that when not really functioning can lead to FSGS. So I think I have convinced you that there are some specific mechanisms by which there can be kidney injury in preeclampsia. But we also have to test this in biopsy. So as far as 1981, there's 178 hypertensive pregnant patients. There's kidney biopsies. Do we actually find there exactly the typical changes? No, we do find them in a very high percentage in primigravida. So this is preeclampsia in their first child. But whenever this does not refer to the first child, but it's the second or the third child, there's a very low percentage of the typical lesions I just described. So maybe we should check for other renal disease that's underlying and maybe flares during pregnancy. There's another study with renal biopsies performed not only during, but over the year past pregnancy for women that were biopsied due to abnormal urinalysis or serum creatinine identified during pregnancy or within 1 year later, controlled with a control group, whereas biopsy was performed in women with the usual indications. And what did we find? They did find that almost 80% of other underlying glomerular diseases were detected in women that were biopsied during or the first year after pregnancy. So we got quite an explanation that's a lot of underlying disease, and there's a very high percentage of FSGS, and I think I've shown you a couple of slides before how this can be explained by podocyte damage. What they also found is that there's a much higher rate of deterioration of GFR in women where the biopsy was performed during or related to pregnancy compared to controls with the same glomerular disease. And it was even higher whether this was performed during pregnancy. So yes, faster GFR loss and acceleration of underlying kidney disease during pregnancy can be clinically presented or diagnosed as preeclampsia. So this is also another case. And maybe we should also check whether there are common risk factors with other chronic diseases that may be associated with renal injury. When we check upon the risk factors for development of preeclampsia, we can find out that concerning the mother, these include maternal cardiovascular comorbidities, classic cardiovascular risk factors such as BMI, diabetes mellitus, chronic hypertension, or lower GFR. The incidence of preeclamptic disorders is 3 to 5 times higher in women with hypertension, diabetes, or renal disease. And the list of risk factors that are associated with hypertensive disorders pregnancy is almost identical to the list of risk factors for cardiovascular disease and CKD. So yes, there's also a bystander element in this association of hypertensive disorders of pregnancy and CKD. Is CKD a risk factor for hypertensive disorders of pregnancy? Yes, it is. We know that women with CKD have an almost 10 times higher, this is a meta-analysis, odds for preeclampsia. We know from a very recent study published in 2023 that the risk is higher as the GFR gets lower. And we also know that for the same level of GFR, there's an additive risk proportional to the level of proteinuria. You can see here between 45 and 60 mL per minute. It gets even worse, the component of risk added by proteinuria when we have a lower GFR below 45. So I think I have proven that there's lots of ways to associate the two situations. But what do we get from epidemiology? Okay, this is a plausible, let's say, way to think that might be association. What do we get? What usually happens after preeclampsia is that vasoconstriction and endothelial dysfunction go away within a few days. Hypertension and proteinuria vanish within 2 to 6 weeks, and even glomerulosclerosis can disappear within 8 years, but there's late residual morbidity. If we examine microalbuminuria, then we can see that a very low percentage of women remain albuminuric, almost a 2% during the first 2 years, but then this starts to rise again 24 months postpartum, resulting to a higher late risk for microalbuminuria, almost 30 to 40% after 5 or 7 years in this later meta-analysis, representing a 4 times higher relative risk. Is this microalbuminuria due to the intrinsic lesion produced by preeclampsia, or is it associated with the other underlying conditions? When excluding women with all the underlying comorbidities, they found that no, there's no incidence in microalbuminuria, so lots of the risk associated with microalbuminuria in these women can be attributed to other factors. Anyway, in this very large cohort, more than 1 million women, average follow-up 18 years, we found that almost 2 to 3-fold higher hazard ratio for CKD in women that have hypertensive disorders of pregnancy. We know that there's a proportional relationship, so there's proportionally higher risk according to the severity of the preeclamptic disorder. You can see gestational hypertension to your left and preeclampsia to the right. The risk gets bigger depending on the level of how severe the disease is. And this is higher for any type of kidney disease. So it's not universal, it's not the same for every kidney disease, but it is higher for women that have had preeclampsia, resulting, if you don't like registries and you prefer matched cohorts as more elegant way to discuss risk, here we know it's almost 3 times higher the risk to have chronic kidney disease, whether this is less than 60 mL per minute GFR or albuminuria. Is this the risk also continues, this relative risk for dialysis? Yes, it does. And it's quite interesting that it rises according to the number of preceding pregnancies. So the first pregnancy, no, but if it is on the second pregnancy or after the second pregnancy, then you get a much higher risk to develop end-stage renal disease. I should focus that this is a relative risk and not an absolute risk. The absolute risk is low, and it also depends on the total number of preeclamptic pregnancies. It's proportional to the severity of the preeclamptic disorder, these two, just like CKD, but you can see that this very high hazard ratio can be largely explained almost to an 80% by adjustment for cardiovascular comorbidities. If you adjust for hypertension and diabetes mellitus, you can see how lower the high risk gets. In any case, this is high. It's almost 5 times higher. And I think I'm just by the time I promised, and chronic kidney disease can be associated with hypertensive disorders in pregnancy and vice versa. And I think that most of this association can be explained almost to 80% by underlying cardiovascular morbidity. Thank you very much.